Oh. Hi, everyone. Welcome back. I'm here with my friend Siobhan Huggins. How are you doing, Siobhan?
Good. Very busy these days, but all in good ways.
Okay, awesome. Because you're going to tell us about what you're learning about with regards to lipedema and also connective tissue disorders. So let's do this. Tell people briefly what your different jobs are and what you're interested in, and then tell us about why you can dislocate your elbow so easily.
Okay. So different jobs. I'm co-founder of Own Your Labs, which is a blood test ordering service. I run that with Dave Feldman. I also do some research with Dave as well. That's kind of how I got my start in the community, looking into stuff like cholesterol and the immune system and inflammation and all that fun stuff. Nowadays, I'm also doing a lot of research work with the Lipedema Project, which is a 501c3 that focuses on lipedema research and advocacy. And the way that I got into that was actually that I was diagnosed with lipedema last year. And that was a surprise to me because it's like, oh, another thing on the list of things that keto helps with. But lipedema is not actually anything I had heard of before people had reached out to me and said, hey, you kind of look like this phenotype, like not to be insulting, but you may want to look into this. I was like, oh, okay, I don't know what that is, but sure. So I ended up talking to my doctor about it and kind of going through it like, oh yeah, this is kind of sounding like me. And the things that stood out were with lipedema, you get disproportionate fat distribution. So that's typically on the lower body. There's different types that show up, but for me, it's hip to ankle. So lower body and then also shoulder to wrist. So over the majority of my body, I have this. And it is also resistant to weight loss. So I've lost a lot of weight, but the fat that is resistant to weight loss is probably because in lipedema, there's fat tissue scarring. So you get these nodules and those are fibrotic nodules. So it means it's like little balls of fat that's encapsulated in scar tissue. And just like if you have a joint that's covered in scar tissue or an organ that's covered in scar tissue, it impairs that fat function. And one of fat's function is to release the fat it's stored, so you have trouble losing it. So I lost the healthy fat. I went from obese to a more normal size for my height, but the lipidemic fat did not come off. And you can actually feel those nodules if you palpate the fat. So you run your hand over it or squeeze it and roll. And it feels like little grains of rice or lentils, or sometimes bigger ones, peas, sometimes up to like apple size. So they can get quite large. So those are two sections of it. And then also with lipedema frequently comes pain. So it's called a painful fat disorder, which makes sense if you think about it. If your fat is scarring, like obviously there's going to be a lot of inflammation in that tissue. And one thing inflammation does is say, hey, this tissue is injured. Please stop messing with it. Don't touch it. Leave it alone so it can heal. But unfortunately, this is a kind of chronic injury that's happening. So you never get that relief of, oh, it's all healed up. It doesn't hurt anymore. But one of the good things with ketogenic diets and lipedema is that one of the things that is frequently commented on is it does help the pain. So I almost never experience painful fat anymore. It is still a little bit tender if you grab it and squeeze it really hard, obviously. Sometimes I'll wake up with some leg aches, probably related to swelling that can come with lipedema as well. And in that case, I put on compression gear and it goes away pretty quickly. So that's the other component is swelling. And I suspect this is also why we're seeing this disproportionate fat. So you have fluid that's accumulating. And one of the things that that fluid does is cause fat accumulation and fat growth. So we can see that in animal models of lymphedema, which is they can do it in genetic ways where the lymphatic system doesn't work properly, or just straight up injure it. And the lymphatic system clears out fluid. So if that doesn't work, you get swelling and fluid accumulation. And they'll see the same type of stuff happening there with fibrosis and all that. So it's a big, it comes with a lot of stuff. It's like, oh, fun, another thing. And then also easy bruising. So you have capillary fragility as well. The blood vessels in lipidemic areas are fragile. And that may be related to connective tissue differences that are also seen in lipedema in terms of hypermobility being fairly common. So that's what you mentioned before, where I'm more bendy than I should be. You can see it in my fingers here, in my thumb. I can, there's a whole scoring system. It's like, yes, you are
Yeah,
definitely
that's
hypermobile.
bendy. It
Yeah. So I
definitely
can
can
also do
touch.
it backwards as
You
well.
can touch your, wow.
Typically they do it this, yeah.
Wow.
So definitely hypermobile. And where the hypermobility is coming from, sometimes it can just be kind of normal. There's variance in tons of things in human bodies. But when it gets to the point of accidentally dislocating things or things like that, it can be a sign of an underlying connective tissue disorder. So for me, I have not luckily ever had accidental dislocation, but I get subluxing, which is basically moving towards that. It's slipping out of place. So that'll happen with my shoulder. I've had it happen with my knees, my elbows, and then also I can pop my thigh bone out of the hip socket. So yeah,
That
it
does
always
not
like
sound
grosses
nice.
people out when I either show them or whatever, but it's not painful. It just feels like you're popping something out of place and
Yeah,
moving back up.
I know how that feels like, because when I was doing this exercise a few years back called the Jefferson Curl, where you're standing on a box and you have a weight in front of you, and you basically like roll yourself up, down, um, as if you're a piece of paper rolling down to your feet, and you have a weight in your hand. So
Mhm.
it's like basically putting a strain on your back, and then you roll yourself, you unroll yourself back up, like if you're opening a piece of paper, and that like works your back basically. And I remember getting, this was early on when I wasn't as strong or mobile, when I would go all the way down, and so my hands would be towards my feet with a weight in my hands, and this I'd feel my hip joint just like slightly elevate. It's no pain at all, like you're saying. I just could feel it's like slipping, subluxing, and I was like, ooh, I don't want to go further.
Yeah, definitely don't push that. Um,
Yeah.
So yeah, there's this cluster of stuff that's happening with lipedema. And another important aspect of it is it's almost predominantly female who are affected. There are a couple of case reports of men, but typically they have something like liver disease or some other cause of estrogen dominance that they start seeing it. So it's like, okay, that's interesting, because we have this predominantly gynoid region that's being affected, and it's almost predominantly, or it is predominantly women. And then also in women who have lipedema, common onset points for symptoms are puberty, pregnancy, and menopause, which are all times of hormonal flux. Menopause a little bit differently because of how things are changing. But I think there's also another component coming in. And this was an idea that Leslie Keith actually mentioned, which is these are also high stress points. Either you're growing yourself, your body, a fetus, or in terms of menopause, this is also where we see women start to develop more rapid rates of heart disease and diabetes and metabolic syndrome. And so they maybe become more vulnerable to underlying issues from the environment or exacerbated by the environment. So you have all of that, and then it also seems to run in families, at least to some extent. Mine is actually not in mom. Like when I went back home to visit my family, it's like, all right, everybody's getting tested for hypermobility, and I'm palpating all of your fat. And the person who's actually hypermobile and is showing signs of a connective tissue disorder is dad. And mom has actually suspected that for a long time. So it's like, oh, maybe you can have male carriers of this connective tissue disorder component, and it's just manifesting differently in men and women. So that was another
Okay.
interesting aspect of it.
So do
So
you
you
know
have all
how
this
these
stuff.
lipedema associated genes are inherited? Are they
We
inherited?
don't, there's some speculation on it, but no gene has been identified yet. And it's an ongoing part of research. Basically, we just don't have enough information. Might be
Okay.
related to X chromosomes, might be any number of things. But the important thing to know about lipedema too, which is why for many of these questions, it's like, we don't know yet, we're still looking into it, all that type of stuff, is it was only identified in 1940.
Hmm.
So compared to things like heart disease, which we can see in like ancient Egypt, and same for diabetes and stuff like that, is really, really newly identified. But another important aspect of researching this and trying to figure out what is happening is that the prevalence is not rare. This is not some rare disorder. You'll never meet anyone who has it, whatever. Or if you do, you'll never meet another. the prevalence in the US is estimated to be around 1 in 9 women. So that is common, I guess.
That's a
So
lot.
go into
That's
a
a
room with
lot.
100 people. Oh, there's actually, yeah. So I'll go into conferences now, and of course I'll start talking about lipedema just as I'm passing by people, chatting, whatever, and I'll start describing it. And then inevitably there'll be like 1 or 2 people who are like, ooh, wait.
Mhm.
And one thing I'll actually do, because it's so distinctive, is like feel the fat in my arm, like touch it like this, if you're comfortable doing that. Do you feel that anywhere on you, especially in the lower body or the upper arms, because that's common places you can find it. And
Mhm.
some people have been like, oh, do you have
Right.
resources on this, because I need to go talk to my doctor about it as a possibility.
So maybe you can, it's a good point for you to distinguish between cellulite and the lipedema type of fat. So, because most people
Mhm.
are familiar with cellulite, and I think that I hear all sorts of things about what it is and what it isn't. So maybe you have a good explanation to distinguish it from what you're talking about with lipedema.
Yeah, so that's actually a good question that I've had as well, because I've heard a whole bunch of information about what cellulite is too, and I'm still not clear on what it is. I know it, or at least suspect it predominantly happens in women. It may be related to fat fibrosis, maybe a different kind, or maybe it is just lipedema that's not being categorized correctly. I actually don't know that
Mhm.
either. So I need to follow up with Leslyn and Catherine of like, what is the distinction here? Because fat fibrosis doesn't only happen in lipedema, it also happens in obesity. There have been studies actually looking at fat loss after weight loss surgery, and they find that people who are obese, who have higher levels of fibrosis in their fat, lose less weight after the surgery. So they lose less
Okay.
fat. So that again lends to fat fibrosis impeding fat loss. But it also happens in lymphedema, like I said. So you have the fluid accumulation, the fat accumulation, and then the fibrosis. But those two are distinct from lipedema in that with lipedema, you get the formation of these nodules. So these little pockets of fat that
Mhm.
are coated in thick scar tissue. Um, so again, cellulite may be something similar to that type of fat fibrosis that we're seeing, where the fibrosis is kind of connected to the fat, connected to the skin, and that's why you see the type of dimpling that's happening. The scar tissue is pulling on the skin,
Mhm.
and it may be related to obesity or something like that. But good question. I would like to know that too, and
Yeah,
then
please
clarify for
let me
everybody else
know.
so everybody
Yeah,
else
when
can.
you have an answer, because I get that asked by a lot of people. I don't have a great answer for them.
Yeah. So the question, if someone has cellulite, that would help distinguish it from lipedema, is when you're palpating that cellulite fat, does it feel lumpy, grainy, bumpy, or is it more smooth and just a little bit tougher? And you would also want to kind of distinguish that further, because in more advanced stages of lipedema, you can develop lymphedema. So you have further swelling from lymphatic impairment, essentially. And then the skin can start becoming fibrotic as well, and then it thickens. So I would want to look in and see if someone has already done that work of saying, oh, here's the difference. I haven't come across anything so far, but it's probably super obvious, and I just haven't used the right search terms. That's always a problem.
So it gets me thinking about the difficulty of losing fat when you have lipedema versus simply an excess of fat. So this, to my mind at least, brings up the question of, so is fat loss really equivalent for everyone? I mean, does everyone have to put in the same amount of effort, so to speak, or get the same amount correctly lined up in order to get some sort of result? And it seems from what you're saying, with the fibrous tissue interfering with the fat release of the fat cell, then that sounds like you could, you're going to be taxed at a higher rate. You're going to lose less fat than another person. So do you have any like figures to quantify that? Has it been measured? What can people expect?
So I think the biggest distinction, I would suspect there are differences in fat loss from, like, let's say straight up fasting, for example, or the weight loss surgery as another example, even within obese tissue, because you would have these varying amounts of fibrosis depending on the health of their fat tissue, how well it's been faring, all that. With lipedema, it would be even more distinct because we have case studies of women with lipedema who have starved themselves to emaciation. If you look at them from the waist up, they look like they are starving because that is what they did out of desperation. But then you look at their lower body down, still looks obese, still looks massive in comparison. And that is really the distinguishing aspect. Like with someone who is obese, there may be less fat loss, maybe it takes longer, but it should eventually resolve. And there are mouse studies actually looking at the effect of beta hydroxybutyrate, so ketone bodies, on fat fibrosis in this kind of obesity context. And they did suggest that it's reversible in that situation. But in lipedema, regardless of whether they're on a ketogenic diet, regardless of whether they're fasting, which you would expect would elevate ketones, we don't see this rapid reversal happening. I mean, I've been on a ketogenic diet for almost 6 years at this point, and no, I still have plenty of fibrotic tissue. That doesn't mean it's impossible. There are things you can do about scar tissue in theory. It just seems a lot harder with lipedema. So I think that's the big thing here, is it's like fasting is not going to get you there with lipedema. You can emaciate yourself. And the scary thing is, like, if you have this massively scarred fat tissue and you're like, I am obese because I look obese, and then you fast. Well, what happens if all but say 20% of your body fat is actually scarred over? Like if you took away all of the lipidemic fat, all of the scar tissue, that is like all of that stuff, and you only were left with your healthy fat tissue, what if that is 20% body fat for you? And then you try and do this massively long fast. That's not safe. Like you wouldn't recommend a lean person with 20% body fat do that. And so that's actually something that I'm speaking from experience here, because I did a 2-week long water fast because I was like, oh, I'm fat. Like I have lots of body fat. I'll be fine. It'll be great. I'll collect blood work, whatever. And it was very strange because it's like, man, I'm still like, I'm approaching a normalish body weight, but I feel so extremely tired. And I feel like this is not in proportion to where my body fat is. And it was actually right after this that people were like, like your proportions from before this fast and during is really looking like lipedema. And these were women who have lipedema themselves. So they're recognizing themselves in my body type.
Mm-hmm.
And so that's actually what ended up getting me diagnosed, is like, oh, I have plenty of body fat. And then, oh my God, I'm so tired. I have to take naps. I feel like awful. And I shouldn't be feeling this way with how much fat I have. So I refer to it now as like being functionally lean. Like my body thinks I am fairly lean at this point. When I went in for diagnosis, the diagnosing physician actually took calipers and measured in places where I had healthy fat. And she was like, I mean, it's a rough back of the napkin type of thing, but it seems like the levels of healthy fat you have are around 25% body fat. It's like, oh, okay.
Which is great for a woman, right? 25%.
Yeah, it's like near fitness levels. I think I might be a little bit above that now, but not bad. Like essentially, I don't really need to worry about that anymore. If I wanted to lose more weight or more fat, I would be focusing on reducing scar tissue and fibrosis, not necessarily like, I don't calorie restrict anyway, and I never have, but other dietary methods, basically.
Yeah. So the question that comes to my mind is, you said that your body thinks that you're leaner than you are because it can't really interact with the fibrotic adipose tissue. So does that mean that people with lipedema have different levels of leptin than a person who has normal excess fat?
So again, needs to be studied. This is something I kind of went through in the research trying to find lab values, and there were some leptin values, but the problem is that not uncommonly, women with lipedema will also have obesity at the same time, or some level of overweightness. So what I would really want is get a bunch of people with lipedema who also have weight issues or don't, whatever, and then put them on a ketogenic diet until they lose healthy levels of the remaining healthy body fat, basically, and see what their leptin does. When I have checked mine, it has been a bit on the higher side, which is interesting. And Yeah, so it's like one of those things where I want just population level.
Mhm.
And the other problem with lipedema actually is if you read through some of the research, it'll be like, we looked at people with lipedema and people who didn't have lipedema from our clinic or whatever, but there's not necessarily a control because it's like lipedema is kind of hard to diagnose and different people have different ideas of what it is and what's necessary and all that type of stuff. So that's also something that can pop up in the research sometimes where it's like, okay, but how do you know that your obese women who are BMI matched didn't also have lipedema? Like, it's possible. So again, I would want like a good sized population and then also have a control along with that so we can verify like they don't have the nodules, they don't have disproportionate fat accumulation, they don't have the easy bruising, all of that stuff, just so we double check, or just check against population controls in general. You
So
could do that too.
by what you're saying, this would be a huge confounder for fat loss studies if they can't control for lipidemic patients.
Yeah, I mean, the other aspect of that too is, a lot of people don't know what lipedema is. Even other researchers, obesity researchers, I wouldn't be surprised. A lot of doctors don't know. A lot of normal people don't know. A lot of just a lot of people don't know what lipedema is. So that's another big reason of why the Lipedema Project focuses so much on advocacy, is not only reaching the patients, but also reaching the doctors and also reaching the researchers. Because yeah, this could be a massive confounder. If it's 1 in 9 women, like what is the chance this is going to show up in your obesity research study, in your weight loss study, in your liposuction study, in your diet study? Like, oh, we tried this diet on a bunch of people who were obese and it didn't work in, let's say, 1 in 9 of them. That sucks. Okay, throw it out. Didn't work. No, wait. It's very possible that the people in your study could just have lipedema and that has completely confounded your results. So this is like something to look into for sure and make sure people are aware that this is a thing, and potentially even exclude people from lipedema for some studies, depending on what you're looking at, or at least identify them, put them in a special group and say, we also looked at these people who have this special condition.
Yeah, yeah, no, that's a good point. So what are you trying to, what are the big things that you need to figure out in your next steps on the lipedema project?
The Lipedema Project, I mean, there's a ton of stuff in terms of raising awareness of what is actually being experienced with lipedema. So there's some stuff on, clinical observations, all that type of stuff, but what are people actually experiencing? Are they experiencing fat bias? Are they experiencing depression, anorexia, all this type of stuff that can come from people seeing you as having a fat body? And there can be a lot of judgment that comes from that. I mean, I still get that sometimes too, of like, oh, why are you talking about a ketogenic diet? You're fat. It's like,
Mhm.
first of all, that's not an argument. Second of all, I have lipedema, and yes, it does make me look fatter. It's a thing that happens. But then also, like, again, making sure we get rigorous research done, looking at lab values, like all of this stuff, trying to figure out how common it actually is. From what I've heard observationally from people who kind of have interaction with them in clinic, it does change depending on the race of the individual. So less common in Asian populations, for example, more common in Caucasians. That also probably suggests a genetic component to it. Especially like, let's say we saw it plenty in Caucasians in America, and they're just assuming it's not as much in Asian populations because they're looking at prevalence in Japan. I would consider that a much different thing compared to, oh, we're looking at Asians from the same population, essentially, which is what they're talking about, basically people in their area in America. So lots of that,
Mhm.
just getting more information. That's kind of the next step,
Okay.
because again, it's fairly young in terms of identifying it, saying, oh, that's what it looks like. This is what we're looking for. Getting a little bit more rigorous about that. This is specifically what we're looking for. This is not what we're looking for. Following up on that, all of that, just more. The other thing is, I mentioned it kind of in passing, but you have the hypermobility aspect that's popping up. And an interesting aspect of that is, it was, let's see, around almost 60% of women in one study. So it wasn't like thousands of people, but is the lipidemic women that they were looking at had hypermobility, so almost 60%. And then when they divided it into stage of lipedema, so this is talking about the severity and how much it's progressed, the hypermobility went up alongside the stage. So as the lipedema got more severe, the hypermobility became more prevalent. So it's like, oh, that's interesting. Definitely interesting.
And does that correlate with fat mass?
Yeah, so with lipedema, you'll see more and more deposition of fat, and then you'll also see the fibrosis getting worse. The nodules will start getting bigger. Eventually, in lipolymphedema, the skin will start getting impacted. They'll develop lymphedema on top, which is what lipolymphedema is, which will further encourage fat development if the swelling goes untreated, all that type of stuff. And it is interesting, but the figure in the lipolymphedema, the most advanced stage they were looking at, was 85%. So it's like, oh, something is going on there. You also have the capillary fragility, which has been said to maybe be from connective tissue abnormalities and lipedema as well. One study suggested there was an increased prevalence of aortic stiffness, which is also something that we see in a condition called Williams syndrome, which is not a connective tissue disorder, but basically what happens with them is it's an inherited condition. And you have a cluster of like 30 genes or so in some specific region. I'm not a geneticist, so whatever. But basically one copy of these genes gets deleted. It's like, oh, so that has a bunch of impact in terms of like facial features and health all over the place. And one of the things that they see is increased aortic stiffness. And one of the proposed reasons for this is one of the genes that can get deleted is ELN, which encodes for elastin. And elastin is a component of connective tissue that kind of gives it that bouncy, rubbery pushback. So when things come in, it pushes back against it, and that's a healthy kind of dynamic. And interestingly, super interestingly, I had read over this line like 10 times maybe, because I would keep reading through old papers, refresh my memory on them. And it mentioned, oh, this aortic stiffness, blah, 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 is also seen in Williams syndrome. It's like, okay, whatever. And then I went and read that citation and came across another one as well. And it was talking about how a lipedema phenotype can develop in Williams syndrome. It's like, wait, what? Because so fat deposition can happen in a lot of different situations, basically. And one component of lipedema that's distinctive is it's location specific. So it's the lower body predominantly, it's women predominantly, sometimes the upper arms and other places, but we'll see this disproportionate accumulation. So that's one aspect, and they have that. And it does skew more towards women, but also men will get it in that case. So maybe a little bit of a different thing going on there, but interesting still. Another thing that they get though, is they get this cuffing. And cuffing is when you are going from this region that has fat accumulation, and then all of a sudden it stops. And so this will happen in the ankle if you have it from, say, the lower legs are affected. So you'll have the lower leg and lots of fat accumulation, yada, yada. Then you get to the ankle, done. And it'll cause this little ridge or sometimes even like a complete fold of fat.
I know exactly what you mean. And now that you say it, I'm like, oh yeah, I've seen so many people with that.
Yeah, and that can also lend towards that being lipedema. And people with Williams syndrome who develop this lipedema-like phenotype also get that cuffing. So you can also get it in the wrist as well. If you're shoulder to wrist like I am, I have some wrist cuffing and then also some ankle cuffing because of where I'm affected. So I want to highlight also, people may be looking at their wrist and ankles right now. If you don't have cuffing, it doesn't mean you don't have lipedema, because let's say you don't have it in the arms, obviously you're not going to get wrist cuffing. If you only have it, say, only in the hips, only in the buttocks, or only say hip to knee, which are all things that can happen, you're not going to get the cuffing because the lower leg isn't affected. But we do see this in Williams syndrome. So that's another, oh, that's interesting. Now, another aspect that there seems to be some overlap is that in lipedema, there's research that's being done and looking into a ton of stuff, a lot of fantastic research. And part of it is that in later stages of lipedema, we can see signs of increased tissue compliance. So instead of that healthy, bouncy elasticity when fluid is coming in, the tissue is kind of like stretching like taffy and just stretching to accommodate and not getting that proper pushback. And what that means is that it looks like it's causing fluid accumulation. So it's exacerbating the fluid accumulation that's already there. And that may set off a whole chain of consequences. But again, in that research, they're talking about this may be signs of connective tissue abnormalities or an underlying connective tissue disorder. And in Williams syndrome, they also postulate that the aortic stiffness and this fat accumulation may be because they have increased tissue compliance. So they also don't have normal levels of elasticity, maybe for different reasons. So it's interesting. It's like, oh, how was this sitting there this whole time and I didn't see it? Because I've been thinking about lipedema for like nonstop for over a year now. And it's just like trying to figure out every single aspect of every single part. And it, like, I find it a lot of fun because you're essentially trying to, like, you have this big box of puzzle pieces and you're just trying to figure out where they all fit. And the symptoms of lipedema are all pieces of that puzzle, and you just have to figure out how they fit together. And then it all starts to make a little bit more sense. And that's just, that's not just a fun aspect, but it plays into a lot of care, because obviously when we're dealing with a chronic condition, we want to have treatment options that address the root causes of the symptoms, or as close as we can possibly get. So with lipedema, you'll often see things like activity is encouraged because activity causes muscle contractions. Muscle contractions help encourage fluid out of the tissue. That's helpful if you have swelling. We'll also see use of compression gear or pneumatic devices, which also help encourage fluid out of the tissue. Also now we're starting to see more use of nutritional therapy because that has just impacts across the whole body. And if it's a good nutritional information, it'll have a lot of beneficial effects across the body. So with use of ketogenic diets, we have some pilot studies now. We have thousands of anecdotes at this point of people saying their pain minimizes, improves significantly, or goes away almost entirely. Their swelling improves. In some cases, their progression even halts or slows down considerably. So all of that is fantastic. They can see improvements in things like fatigue, in terms of, I mean, depression and anxiety too. I had depression before I went keto. Is that related? I don't know. It seems like it was metabolically related because it improved when my diet improved. And if my diet kind of slides off, it'll worsen again. So that's kind of a question I get sometimes were you depressed because you were obese? Well, no. Like my depression improved 2 months into a ketogenic diet. I had lost 20 pounds at that point, but I had lost 20 pounds plenty of other times, and it didn't cause this spontaneous remission. So that's another aspect. You may have mental health difficulties because you're dealing with this chronic condition and nobody really understands and you get a lot of judgment for it. You may also have this chronic condition that is relating more towards poor mental health, because it may also be related to things like hyperinsulinemia and poor metabolic health. So that's another thing that should probably be investigated is, are these two things clustering or working off of each other? Both are occurring and playing off of each other. And then how do we treat that?
So
yeah.
Talking about how do we treat that, do you have a checklist for doctors to be able to spot it?
For lipedema, yeah. So I had done a presentation for low carb bokeh, and the first section of that presentation is, here is what lipedema looks and feels like. Here's what people may describe when they experience it. And here's how to differentiate it from obesity, because that's a problem, of course, right? Like you have a patient coming in, I try to diet all the time, it doesn't work. That's true for a lot of people. A lot of just typical obese people have problems trying diets and they don't work. But how specifically is it not working? Are you saying you're losing weight, but you're losing it mostly from your face and upper torso? Or is it that you're trying to lose weight and you're just not really seeing weight loss in general? I mean, both of those things are potentially related, but also potentially distinct issues. So we need to investigate that more. Second of all, the presence of nodules. There's plenty of places you can spot them. One of them is actually on the back of the knee. There's a fat pad there, the medial knee, I think it's called, and you can palpate there. Nodules are very common at that point. You can also check the upper arms, the umbilicus. So you basically stick your thumb in their belly button and palpate the roll of fat there. And you're looking for graininess, bumpiness, all that type of stuff. And people can do this on themselves too. That's what I did when people suggested it to me, is I'm like feeling my fat. But then the problem is like you feel something on yourself and it's like, well, that's normal because you've had it basically your entire
Right.
life. So then I went over to Amber and I was like, can I feel your arm fat just for comparison? And her fat felt very smooth, very healthy. So kind of like the fat on a pork chop is the way I would put it. And so it's like, okay, so there's this very smooth, firm, bouncy texture. Then mine was very like it pulled. It's almost like a taffy pull. It's very stretchy, at least in me. Very grainy and bumpy, lots of bumps and all that type of stuff, and just very bizarre. And then also the proportions, like my waist, completely normal waist size for my height. Like I am not obese, not like abdominally obese, not anything. But if you look at my thighs, if you just disconnect the picture again, it's like, oh, that person must be obese or overweight because of how their thighs look or how their arms look. And my arms is something I've always been self-conscious about as I was losing weight, because it's like, they're still so fat. It's like, well, yeah, if you feel it, it's like just riddled with scar tissue. Of course, that's not going to shrink down to a proportional size if that's the case.
Right. Okay. So that's interesting that you have that checklist ready. I'm definitely gonna screenshot it from the presentation and use it at the
Yeah.
clinic. Because if it's 1 in 9, like you say, that's super high, and that's a lot of people who would benefit from understanding what lies ahead of them.
Yeah. And another, what do they call it? Like a differential diagnosis is you want to exclude lymphedema. So again, that's a lymphatic disorder. It can be inherited or it can be acquired. But what you'll see, the main differences between those, and I talk about that in the presentation as well, is that with lipedema, if it's only lipedema and not also lymphedema, because both can occur at the same time, it'll be symmetrical and it'll be bilateral. So it's on both sides and it's proportionate. So you'll see that in lymphedema, you could have only one limb affected, only one leg, only one arm, whatever, or it could be in both legs, but one will be substantially bigger than the other potentially. The other thing is with lipedema, I mentioned there's swelling of the legs that comes with it, but it doesn't affect the feet if lymphedema isn't also present. So you can do what's called a stimmer sign. Basically, you pinch the skin at the dorsal of the feet, the top of the foot, basically next to the toes. And if you can pinch it, there's not lymphedema in the feet. But if you see these other signs of lipedema, that points towards lipedema. If you can't pinch it because it's so swollen with fluid, that suggests lymphedema, which doesn't rule out lipedema because they can both occur. But then at that point, you would just want to investigate further and kind of see, hey, did this develop later on? And you had these problems prior to that kind of thing. So a lot of people actually get diagnosed with lipedema because they get diagnosed with lymphedema, sometimes accurately, sometimes not accurately. They get sent to the lymphedema clinic, and then that person there is more familiar with lipedema, and they say, oh, you actually have, or you also have lipedema. So
Okay,
it's
so
pretty fascinating all around.
yeah, and so give me like an estimate at the moment. How much of lipedema do you think is genetic versus environmentally caused?
So my current standing at the moment is probably that there is a genetic component. So there's a predisposition that's being passed down. But we can also say the same about Ehlers-Danlos syndrome, for example. Ehlers-Danlos syndrome is another connective tissue disorder. It's actually a wide umbrella of them, and there's different types. But with hypermobile Ehlers-Danlos syndrome, for example, there's not an identified gene. It does appear to be at least somewhat genetic. And we can see at least a couple anecdotes of people saying, hey, I changed my diet and my Ehlers-Danlos syndrome symptoms got better. Or usually what I see this is from people who've gone low carb, keto, or carnivore. And I've even talked to a couple of people who said, I went low carb, it was good. Went keto, it was better. Went carnivore, it was even better. And to me, that suggests that, so you have this inheritability component, this predisposition, and then environment is either triggering the symptoms or exacerbating them. And I think the exact same thing with lipedema. And I think that because we are seeing symptoms being modified by diet and lifestyle factors too. But so when people go keto, like myself, I have not noticed any progression in the nearly 6 years I've been keto, except for when I did a high carb experiment that made me hyperinsulinemic for a period of time, made me gain weight basically. And then I did see, as far as I could tell, progression in lipidemic areas because I gained fat. And when I lost the majority of that weight, I still had 10 pounds of fat left that was not coming off. And when I did a follow DEXA, it was in lipidemic area. So it was in my thighs and arms, basically. So there do seem to be environmental things that can trigger it. So that's another reason for people to get diagnosed is like some people may be able to go on a holiday and binge carbs if they're on a ketogenic diet. They come back off the holiday, they get right back into the diet perfectly fine. That may not always be the case with lipedema. You may need to especially be careful if you have these potential progression triggers. And also just knowing that there are lifestyle things that can impact this. The pain is a major thing. Being in pain all the time, speaking from experience, sucks. It also sucks when people don't understand it because people would grab my arm to get my attention. I'd be like, oh, ouch, that hurts. Like it's stabbing pain. Like they just like almost like they had gripped it with the amount of force needed to bruise me, but it was really just a gentle, hey, can I get your attention type of thing. And then they'd be like, why are you exaggerating? It's like, I'm not exaggerating. That hurt, dude. Yeah. So again, like all this type of stuff, just, yeah. So genetic predisposition, I think is a fairly good bet.
Okay.
But I also think, I mean, the sex hormone component, I'm not discounting either, because again, we're seeing it predominantly in women. In the case of classical lipedema, not related to Williams syndrome, but even in Williams syndrome, apparently it still skews more towards female anyway. And then also the onset periods, a little bit suspicious. So you have puberty, pregnancy, menopause, again, hormonal, and at least puberty and pregnancy, those are also times of gaining fat, like specifically fat. And gaining fat in female areas in this gynoid region, which is where we're seeing lipedema. And then there may also be some physiological differences in how they're growing fat as women, more skewing towards hyperplasia as opposed to hypertrophy, which may factor in. So, yeah. But yeah, combination of things, which is good because if it's a genetic predisposition and then you can modify it with environment, that's actually good news as opposed to solely genetic, because it means you can intervene and do things about it, which is always what you want. Kind of like with Alzheimer's, you know, the ApoE4 thing, genetic predisposition, probably modified by environment.
Gotcha. That's super important.
Yeah, actually, what I'm wondering about, what I'm really curious about is, you know, in people who are metabolically healthy, who have this genetic predisposition, what do they look like? Like, do they still gain the fat and it's just healthy fat? Because that would be pretty interesting. But we don't have that information. Like we can't identify children who are going to develop lipedema because we don't have a gene, we don't have a blood marker, we don't have much of anything at that age level yet. So if we could do that, observe what they look like as a healthy person, metabolically healthy, that would be super fascinating because it may be, you know, like excess fat growth, if it's subcutaneous fat, whatever, that's not a big deal. Especially if you can access it later, if you're starving, if you need to nourish a fetus that you're attempting to grow, that's not too bad a deal. But if you're then scarring that fat over, you can't access it, you're starving, you have all these fat stores that are locked away, that's not helpful. And as common as it is, I wouldn't think that this would be like as common as it is if it's that detrimental in terms of survival out in the wild. Like just a random thought, I guess.
Yeah, no, that's what you mean. And do we have any data looking at oral glucose tolerance tests in people with lipedema? No.
So this is another pet peeve. So in the research, you'll see things like women with lipedema are less likely to have diabetes and cardiovascular disease or metabolic syndrome, yada, yada, yada. But here's the trick. Like if you had looked at me before I went keto, you would not have looked at me and said, that person has lipedema, I'm going to diagnose them with lipedema. And oh, look, they have hypertension and fatty liver disease and like all this stuff. You would have looked at me and said, she's obese, and you would have left it there. So it's very possible that that same thing is happening in terms of diagnosis because one, people don't know what lipedema is, and two, obesity is fairly common in the US anyway. So it's like, all right, they're obese, whatever, get out of here. Meanwhile, the people who are non-abdominally obese, who would therefore be less likely to have metabolic syndrome, the disproportionality of the fat growth and the resistance to weight loss is going to be more obvious. And then you look at them like people looked at me at my body fat level now, when I'm non-abdominally obese, when I'm not obese, and said, oh, you look like you have lipedema. I'm going to diagnose you with lipedema. And then they get put into these studies, right? So it's this sort of issue. Is it actually a protective factor? I find it less likely than it's just people who are severely obese, have metabolic syndrome and lipedema just aren't getting diagnosed at the same rates. And then again, in terms of insulin levels, there's one case study that looked at a woman with lipedema, her insulin levels before a ketogenic diet and then after being on a ketogenic diet for like 22 months. And the starting insulin level, they didn't report on whether she had metabolic syndrome or not, but her starting insulin level was at 30. So it's like,
super high.
Okay, yeah. And you could probably hedge a bet. I didn't have my insulin levels tested before going on a ketogenic diet, but probably fairly high given the hypertension and probable fatty liver and all that. So that's like, I got asked during a panel at Low Carb Boca, like, what is your most pressing want or desire for lipedema research? It's like, I want baseline insulin levels. That's what I want, because that's another aspect. If this is a disorder that's getting exacerbated by a metabolic problem, then we can recommend even more strongly, we need to get their metabolic health under control as part of this disease management. Like, sure, you could say, yeah, it's probably helpful now because of the weight issue, the fat gain aspects, yada, yada. But if this is massively common, then okay, that needs to be like first line target. Like, okay, you have lipedema, we need to be really careful. We need to get your baselines. We need to make sure we're on top of this. Like, not only for the fat gain aspect, but metabolic health impacts everything, like everything. So I can imagine a situation in which poor metabolic health is impacting your ability to heal from tissue injury, which appears to be happening in lipedema, connective tissue health, which may be an important factor of lipedema, mental health, which may very well be an important factor in lipedema, like all of this stuff. And not to mention, like, systemic inflammation is going to impact swelling. It's going to impact swelling in the legs. And people have commented on that before, that if they're on a ketogenic diet, so they're keyed in to feeling good, they have something, some type of food that doesn't agree with them, they'll get swelling very rapidly. And they can feel it. Like, you can feel the tightness of your skin, the heavy feeling in the legs, you can feel it happening. And again, this is going to be impacted by metabolic health. You don't want that happening all the time. Like, inflammation is wonderful. It does many wonderful things for us. But if you are requiring it all the time, I'm going to hedge a bet, at least at high levels, that something is wrong. It's not the inflammation's fault. We understand you. But at the same time, it's a check engine light of a very high degree, same as hyperinsulinemia. Like, insulin has a purpose. It's not evil. We love insulin. But if you have insulin of 30 all the time, something is going on and we need to work on that. So yeah, tons of just, we're learning so much about lipedema, and it's very exciting and fascinating. It's fascinating disorder. Like, it's funny to talk about because I have it, it is very annoying, and I don't like that I have to be more careful than other people may have to be lifelong, essentially, and that I have to worry about things like pregnancy because that can exacerbate symptoms. But at the same time, it's like it the symptoms can kind of interlock together in a way that's very fascinating. And if you work backwards towards, oh, this may be what's happening, it's puzzle solving, basically. So I find it entertaining and irritating, and also understanding this is a real issue for a lot of people. But if we can focus on this puzzle solving, then we can help a lot of people at the same time. So that makes it double the fun.
No, that's cool to hear. I think it was in Gary Taubes' book was the first time that I'd heard about lipedema. And those really like striking examples that he shares in the book, where you can see this change in body fat distribution between the upper parts of the body and the lower parts of the body. That's sort of what really drove home the point for me that it's not only the amount of fat and how much you eat, but the quality of what you eat and the quality of your fat, meaning where it's distributed, its fibrous status, how well it's able to release fatty acids. There's so much more to it than the quantity aspect.
Yeah, probably second to the liver, fat is one of my favorite organs. And it's because it's so complex and cool and it does so much for us. Like fat is awesome. I love having fat. I love being a very, very fatty primate. It has gotten us very far in this world. But in that same vein, I want my fat to be healthy. And this is one of those shifts that I have had in terms of learning about metabolic health and my own health and all this, and coming to understand that it's like I didn't become obese because my body was trying to hurt me or make me sick. And people probably maybe don't develop heart disease because their body is trying to kill them or make them sick. And maybe that these signs, these symptoms are really evidence the body is trying to keep us alive. Like the scar tissue is not like, oh, I had a bad day, I'm going to scar over this tissue that I need to live. Like, no, there's a long process behind that of we tried everything else and it's come to this, like we're getting this repetitive injury signal. We really just have to do whatever, keep the integrity if it's in the heart, keep whatever it is that causes that. So it's now instead of like, oh, I have to fight against my body the whole time to get to good health. It's like, no, if I actually listen to what my body is telling me in terms of pain, in terms of energy levels, then I can actually work with my body because we do actually have the same goal, being in good health, having a family, having a happy life, enjoying ourselves. All of that is like not a fight. It's actually a cooperative effort.
Well said, well said. So on those words, give people your social media, your Twitter, your presentations online, videos, all of that good stuff.
Yeah, so you can find a bunch of my presentations on YouTube. My Twitter is at Siobhan_Huggins. Please provide that in the show notes so they don't have to try to spell it. And I'm mostly on Twitter, not as much these days, just because I've been busy and social media is a lot. But I am active there and I'll respond to questions and stuff there as well. You can also find me over at the Lipedema Project, where we're doing a lot of very cool and exciting things. June is actually Lipedema Awareness Month, so we have a whole month-long event. I'm actually giving a presentation for that. Let's see, on this upcoming Sunday, actually. I don't know if this will be out before then. But I'll be talking about essentially what I think is causing lipedema, so a possible model for what may be happening. And again, it's important to understand that so that we know what we're treating and how to treat it, so we're not confusing things and trying to stop things that are actually helpful or whatever. Yeah, I'm on Facebook too, really not as much, mostly Twitter. And yeah, and you can find my one of my lipedema presentations on the Keto Mojo website. Just look up lipedema. We also have an article on lipedema and ketogenic diets that you can print out, take to your doctor, whatever you want. It's about a 10-minute read. So if you want to get caught up on everything, get your doctor caught up, especially if you have it or suspect you do, then that would be a pretty good resource.
Okay, that's really cool. I'm going to use all of that in the clinic materials we have for the clinic in Lisbon, Clínica Ferro. So I want to make sure that we're on top of it as best as we can. So that's really cool. Thanks for educating me on all this. There's most of it that I had no idea about. So this is really cool for me. It's a treat. Yeah, and we'll do this again. When you've got some updates and some new insights, we'll definitely do this again. So thanks for listening, everyone.
Yeah, thanks for having me on.